All right, so I'm thankful that the rest of you decided to stay. It's raining. I know it's the last session of the program, but y'all are going to get a good bang for your buck here. Okay, so a lot of what I do in my practice is helping providers build out telemedicine arrangements, right? But another component of that is really a lot of policy and advocacy. Do I get paid for that? Not so much. It certainly has a back end because it helps my clients in the industry just get more traction and more revenue opportunities. I also just find a personal interest in it. I think it's a lot of value. So while I normally talk about how to build contracts that are viable, sustainable, robust, how not to rely on grant funding, how to think about ways to have both parties with skin in the game, today we're going to talk about politics and process for policy, and really how these rules and laws affect the actual marketplace, the private marketplace. We're going to focus primarily on commercial insurance law, and then I'm going to use the Matric States as exemplars. I'm going to go through the good, the bad, and the ugly, and then I'm also going to use as a case study the Florida Telehealth Association. I'm the chief legal counsel to that. It was created last fall as pretty much a single-purposed vehicle to allow all the healthcare providers interested in telemedicine in the state of Florida to, rather than tapping all their individual legislators like that, work together and have a single fist that is a point of entry. They were able to get a bill passed. Governor Scott has until Thursday to sign it, and if he doesn't sign it, it'll automatically become law because Florida does not have a pocket veto. We're optimistic that he's going to sign it. I'll talk about how that plays out. I also want to drop 2 bits of breaking news on everybody, which you'll probably find particularly interesting. The first is yesterday afternoon, the White House announced a new Medicare program regarding Comprehensive Primary Care Plus. Has anyone heard about this? All right, one guy, okay. What it means is it's going to be a 5-year program. Approximately 20,000 PCPs will be able to participate, and it'll cover what they estimate to be 20 million Medicare beneficiaries. There will be 2 tracks. Track A is sort of like telehealth light, and track B is a bit more of a commitment. For track A, those doctors will get an extra $18 per patient per month automatically. In exchange, they're going to say you will make some commitment to reach out for continuity of care and be available 24/7. Track B, those doctors are going to get $28 a month per patient, and then they also have to have a certification with their vendor that they're going to make these efforts to engage the patient. So all you telehealth platform vendors out there, you definitely want to pay attention to this because it represents a major market opportunity for you, well and beyond the CCM code that went live last January 1. So that's the first one. The second one is the Robert Wood Johnson Foundation, just like yesterday, put out a report about health insurance plans' use of telemedicine as a way to manage narrow networking versus broadening network access. We're going to talk about that because some of these state laws, including states in the Matric organization, have language allowing health insurers to develop narrow networks for telemedicine, which means that if you're a telehealth provider, or if you're a regular healthcare provider and you're in network, you have a contract, you might still not be able to provide services via telemedicine and get paid by that health plan because you are not in their preferred telemedicine network, which in my opinion is kind of BS, but that's because I represent providers and not health plans. Okay, next slide. Telehealth coverage. Why is telehealth coverage important? I remember yesterday talking with some of the people here, and one of the questions was like to a speaker, I find it repugnant that you're talking about reimbursement and revenue so much. The focus should be on patient care. Okay, I get it. The focus really should be or is patient care, but any of you work for nonprofits know no money, no mission, right? That's a clear mark. If you can have the most fuel efficient car or the most expensive Ferrari, and if you don't have any gasoline, it's not going to go anywhere. So I think it's unfair to put an additional burden on the providers or the telehealth program directors or whatnot who are already struggling to connect those dots with their CIO, the CFO, and whatnot, because sometimes the telehealth program directors, they get it and they understand, but they don't have the institutional authority to make all these decisions, right? So you're already putting an inordinate amount of ROI-proof pressure on these people who really are operational types. And then you're saying, oh, you shouldn't even care about money. Well, maybe if you're born into it, you don't care about it, but a lot of people, working on it do care, and it is important. So that's why telehealth coverage is important, but why is it particularly important here Let's talk about the nature of healthcare, the role of insurance as an intermediary versus retail medicine. Everyone knows retail medicine is taking off, right? And you can see a direct value, direct purchase. Why? Because as an individual consumer, I can speak with my dollars. I do that when I want to buy a car, right? Ford knows it, Chevy knows it. They have direct buyer incentives. With insurance, you are totally disenfranchised as a patient, and you are unable to speak with your dollar. Why is that? Because someone else, you're paying premiums to someone else, right? And that entity is the insurance company, who then gets to choose the network of providers that are in network. Yes, you can have a PPO option, and you can have an out-of-network provider, and you can pay more money out of pocket, and to some extent, you're speaking with your dollar. But really, should it be like that? Even more, it's even more removed. As an employee, so I'm a partner at my law firm. I do telehealth, all the time. I don't even have a telehealth benefit among my benefits package, right? It's embarrassing, I have to explain it to my clients, and they're like, oh, we'd be happy to provide it to your law firm, blah, blah. Of course they would. I don't even have the ability. I'm not a management committee. Even management committee might not even know, really, because we have a contract with United, and the benefits are perfectly fine. My wife wanted to have some telepsych consult. There's nothing available. Okay, that's kind of a shame, and it shows again that I'm not making any of those decisions. I may be able to get to choose who my employer is. I certainly don't get to choose who my employer's selection of a health plan or a TPA is. Within that, I certainly don't get to have any say in the benefit package or the scope of benefits and what's covered, much less the nature of who's in the network. So it really is divorced, right? That's why we need these laws. That's why in the states, the 21 states that do not have a commercial coverage law, you do not see a significant amount of traction by and large, right? Even in those states that have really poorly drafted or watered down versions of these commercial coverage laws, those providers that have traction are the ones that proactively reach out to the health plans with a value proposition and say, we want you to put us in a network or whatnot to cover telehealth services for your enrollees, and here is why you should do it, right? So I don't have a ton of sympathy for providers who just sit on the sidelines and complain that the plans aren't reimbursing. If my next question is, have you even reached out to your provider contracting rep or the plan to see if they're going to cover it for you? Because then they're just like, oh, that's not my job. Well, no, it is your job. If you're a big advocate and you want to get paid and you see value in the service, just reach out. And I do talk to people at plans, and they say it's surprising how few providers actually do so. So you look at large companies that are well established and entrenched, Teladocs, MD Lives, American Wells. It's not that they're providing something that is so cheap and affordable that it's attractive to insurance companies, but they approached it with a value proposition, saying, look, you're going to pay us X and Y, and we're going to deliver this, and this is why it's going to have cost savings. You can do the same thing because we talk about it all these sessions about the cost savings, care improvement. Patient choice, again, so the other issue that you might get a lot of pushback, particularly if you're in a state like Florida or with a conservative legislature, is they'll say, we hate mandates. No mandates, right? Can't tell anybody what to do. Certainly can't tell an insurance company what to do. What with their lobbyists, they'll go crazy, right? It's not a mandate, in my opinion. It's a consumer rights issue, and let me explain why. As an individual, already I have very little say with regard to the selection of insurer or whatnot. But fundamentally, I am paying an insurance company a premium in exchange for a set of services, right? My premium in exchange for the benefit package. That's a contract. I'm going to pay $1,000 a month premium, and they'll say, Nate, I'm going to cover 100 different services for you, right? It is arbitrary for that insurance company to say, yes, those services are covered if you're sick, whatever. However, you have to get them in person. And there's no clinical justification or support for it whatsoever, right? I should be able to receive those virtually or in person these days. And to say no, it's arbitrary. I have bought that service. I haven't bought the service mandated that it's going to be in person. And when you look at it in that way, you say, well, really, it is disenfranchising the individual consumer, the purchaser of this benefit, right? So many providers look at it, I'm a provider, here's my patient, somebody's got to pay me, right? The providers who are very successful in negotiating with insurance companies for coverage don't look at it as a provider-patient. They say, how can we treat your enrollees, okay? Because that's what health insurance plans call their members. They call them enrollees or members. And when you look at it that way, and how the health plans get paid and what they do with their money, you'll be in a much better position to effectively negotiate for coverage with your particular provider or institution. All right. Not going to go over Medicare rules, but I do want to say this is kind of an early release. The official report hasn't been out, but we did get a copy of the numbers from CMS last year. And another plug for my blog, if you haven't read it, there is a whole article on this, all about the 2015 Medicare payments. So what this chart is designed to show is that last year represented a 25% increase over in payments and claims volume in traditional Medicare fee-for-service, right? In 2014, you had about $14 million paid, and 2015 was 20% more than that, 25% more than that. Medicaid, you have, this is from LaToya Thomas. She's excellent, works at ATA, put together this map in connection with her policy advocacy gaps analysis. 48 states cover it except for Connecticut and Rhode Island, okay? Commercial insurance, here's another thing. They'll say, oh, health plans are covering it, and health plans are really moving faster than Medicare. I don't know if that's really true. Medicare has a hesitation, not necessarily just from CMS. Keep in mind, the term telehealth services is a statutorily defined term under the Social Security Act. CMS is not authorized just to blow the doors open and disregard the legislative parameters of what is and what is not a telehealth service, right? That's why we're having all this discussion with federal legislation back and forth, whether it's the CONNECT Act or the Medicare 21st Century Cures or Medicare Telehealth Act of 2015, the Parity Act. There's a multitude of approaches. Yes, there is a potential concern that it's a budget buster if you increase access to drive up utilization in a fee-for-service reimbursement methodology. But as we'll get to in a slide, CMS is really moving away from that fee-for-service methodology, right? Insurers, on the other hand, this is a really great study. It came out about last month from the Healthcare Cost Institute. It analyzed claims from insurers from a payer database from 2009 to 2013, okay? 6,500 telehealth claims in that 4-year period by primary care compared to nearly 96 million non-telehealth. What's interesting, every single year, the reimbursement rate for the in-person service increased. Okay, you get it. Doctors like, you got to give me more money, you got to give me more money, let's increase it. They increased for telehealth services as well for the first 2 years, but in 2011 they actually decreased. 2011, 2012, and 13 decreased. So anybody who's saying, oh, all we need is a coverage law, payment parity doesn't matter, well, they'll pay us the same rate. They do not. And in fact, this report shows that they paid 40% less than the identical in-person service. Why is that? There is no justification other than let's find an opportunity to pay less, or the providers are not effectively negotiating, because the rate at which you get paid really is a function of your private negotiating with a particular payer, okay? California and New York, states with very large populations, had very few claims compared to their populations for telehealth. Now, New York at the time, 2009 to 13, did not have a telehealth coverage law. They do now. California did. And that's another example. I don't know if anybody has ever worked in California with telehealth. Some, yeah. So I used to live there and work there at my firm's LA office. There is a telehealth statute. It was one of the early ones that was enacted, but it is so vaguely drafted that plans say, okay, fine, we'll cover it, but we're going to impose a bunch of conditions of coverage, and it'll be just like Medicare, and nobody gets paid. There are some exceptions, but again, it shows you the impact of these statutes. My apologies to Kentucky. I left you off inadvertently, but here's the state, the 29 states with commercial insurance laws. I highlighted in green those who are members of this group. Let's see. Here's the Matric States. Here's the Matric States with coverage laws. And oh, okay, now we're getting a little smart here. These are the Matric States with coverage laws that say broad coverage and parity, if it's in green. So Virginia and Delaware. Who's here from Delaware? Give yourself a round of applause. You guys did a phenomenal job in this statute. I was at they had those state-by-state breakout sessions yesterday, and I was like, well, what should I attend? I'm like, don't live in any of these states. So I figured if I went to Delaware, it would be a bunch of people just high-fiving each other and talking about how much like they're getting paid and everything. So I chose to go to the Maryland one, and it was like, wah, wah, and nobody's getting paid. So I see Mike over there. I know he's involved in the Delaware legislation. That's an example on the far side when you look at all these 29 states of what it looks like. It's, I mean, someone could say it's like overboard in pro-provider, which is great if you're a provider. Other states are the opposite. We're going to talk about it. Here is a list nationwide, states with commercial insurance laws. And then here's a bit more of a nuanced breakdown. Now, this is different from what ATA does, and Latoya's reports and Gary's reports are great. Those are policy advocacy pieces too, right? So this is from a little bit more of like a legal interpretive approach, and it shows you the yellow states have limited coverage, right? And with limited coverage in the language, that's what the market reflects, limited coverage in reality. The green ones have broad coverage and payment parity, and the blue ones have broad coverage and no payment parity. So let's talk about for a second what's the difference between coverage and payment parity. Coverage says if my insurance benefit covers a service when provided in person, the health plan must also cover that same service when provided via telehealth. Pretty simple, right? It says nothing about how much the health plan would have to pay for it. Payment parity is the second level that's usually applied to some of these statutes that says not only must they cover the service, but they must pay at the same or an identical or equivalent rate. Sometimes they say the same basis or the same rate, or if you're Minnesota, you say the same basis and the same rate, okay? Again, this is very important. Massachusetts, like I think 3 years ago, passed a law designed that all the providers thought would have commercial insurance coverage. But the way it was drafted, lawyers at the plan sliced and diced it, and they said, psh, okay, fine, we don't have to do anything. And they didn't cover anything. And so like you blew all that political capital, right, trying to get a bill passed, and everybody's shaking hands, and all of a sudden the language at the end of the day is like, the leftover lettuce in the bowl after lunch, there's like a couple shreds, it's like just nothing. And now they're back at the drawing board, and they're proposing some new legislation as we speak, okay? Talk about a disappointing merry-go-round. All right, here's another cool breakdown, and my apologies for this, but the slides are all available, so you can get them from Kathy through the app or whatnot. Here are your states broken down into some cool categories, Does it have a statute at all, okay? So New Jersey, Pennsylvania, West Virginia, and then is there broad coverage parity? Yes, no. Is there payment parity, which I discussed? Are there originating site limits? And none of these have any like originating site limits of note. Is there a cost shifting protection, right? Some of the statutes say, look, you can charge deductibles or copays to the extent they do not exceed the deductibles or copays that a patient is responsible for when they receive an in-person visit, right? Because some of these states, the plans are like, sure, patient, you can get a telehealth service, but now you have a higher deductible, you have a higher copay requirement. Again, it's a disincentive to utilize it. Do these states have any planned network limiting language, narrow network? So Maryland and Kentucky, there is some language there that talks about being an in-network provider and not necessarily getting access to these services. And some of that language can be interpreted one way or another, but you do not want that result in a statute. A statute really ought to be clear on its face, and you do not want to have to try to resort to legislative history or like a war of letters between lawyers from a health plan and lawyers from your provider, because it's not going to benefit you, not going to get you anywhere, right? So I think in the Maryland, I'm correct from yesterday, you were talking about one of the experiences you have is that plans are saying you might be a contracted provider, but you're not in our telehealth network, so we're not going to pay you for telehealth claims. Is that correct? Yes, no? Excellent. So I presume that if it were not vague, then you would have been getting paid in the past. Okay. Are RPM, does it cover remote patient monitoring? That's really the next frontier. Why does that need to be separate? And again, props to Delaware. That's not in the statute, that's in the regulation. Mississippi is another example with RPM. They passed their telehealth year 1, then added RPM year 2. Why do you need to do that? It's separate. Most RPM, by its nature, it does not have an in-person equivalent. So most people do not have any patient benefit package for an in-person services that would include remote patient monitoring. It's definitionally inconsistent. It's an oxymoron. So that's why you can't easily include it. Any states that do have RPM coverage, it would be a separate line or a separate subsection within the statute. So all of you people who have CCM or other RPM technologies and deployments, don't hold your breath that you're going to get paid even if you have a commercial insurance statute. You might, but you might not. And so you need to think about that as an additional. And then store and forward, async, and then a licensure exception for out-of-state doctors. No states have that, but Florida was thinking about it. And then here's the pinpoint authority so you can do your research. All right, we'll talk about some of these statutes right now and how they look. Delaware. Each insurer shall provide coverage. That's good because it's proactive, it's affirmative, right? We like to see some of that in statutes. And then they also really belt and suspenders, and they will not exclude coverage solely because it's provided via telemedicine. Then later on, the third bullet point, it talks about the same basis and the same rate, and at least the same rate that the insurer pays for an in-person service. And then they'll also say you're going to include in that payment reasonable compensation to the originating or distant site for the transmission cost incurred. Wow, that's your software, that's your platform, that's your connectivity. Delaware might be the only state that has all of that language all built up. So again, that is all advocacy, that is all legislative drafting, and once it's in the law, that is what it is. And then the next bullet point basically has the cost shifting protection on copays and deductibles. And then they say, look, you can't impose any different lifetime benefit cap or whatnot different from the in-person. And there's the sites right down there under the statute and the insurance code. DC, all right. Same one. They don't have the affirmative, but they say may not deny coverage. Some states have done that. I think the model language I'm going to give you at the end of these slides will be more proactive, and I think that's preferred. They'll not deny coverage on the basis it's provided through telehealth. They shall reimburse, but then they have some carve-outs. So they say they don't have to reimburse if it's not covered. That's fine. Largely, it's kind of redundant language from the top. But they don't have to reimburse a provider who is not a covered provider under the health benefits plan. And this is actually the exact same language Maryland basically copied, or DC copied Maryland, one of the two. And then again, that is a hook for narrow networking or contracting, right? It could be interpreted just to say I'm in network or not, but it could also be interpreted to allow the plan to create a telemedicine-only narrow network. Some state statutes go even further and expressly say the state is allowed, the plans are allowed to do that. Then they got some patient protections, aggregate and whatnot. They do have something here about utilization review. And so they say you can do UR provided the determinations are made in the same manner as those regarding the same service when it's delivered in person. It's kind of a prophylactic measure. I kind of like it, though. It does make sense, because these plans really have imposed a number of restrictions. Some states have addressed this by saying you cannot impose any originating site. You cannot make any determinations based if the patient is rural or urban, location or whatnot. And so again, this is just forward thinking. All right, Virginia. Well, let's go to Maryland. So Maryland is nearly identical, but it's worse, okay? Look at the first bullet point. We saw how DC was, this is almost identical. However, they say they shall provide coverage for services appropriately delivered through telemedicine, okay? Now, if I asked y'all, what is the service appropriately delivered through telemedicine? You'd probably be like, well, everything, right? Maybe not open heart surgery, okay? But this room skews to one side. If we got in a secret room with a bunch of insurance companies and said, okay, what service is appropriately delivered through telemedicine? They'll say, well, depends how much these people actually access and use these services. Let's make that determination later on after we see how the numbers shake out, right? This is soft, it's soft, and it provides an opportunity for health plans to not pay, right? If the purpose of that bullet point is to mandate coverage, why would you include qualifying, softening language in it? Okay, these are just things, I'm not trying to beat you guys over the head, I'm just trying to like enlighten and think about these kind of things because you always have the opportunity to, at a second bite of the apple, to revisit statutes. And in fact, that's what a lot of states are doing. These are excellent ideas and the states passed them early on before ATA and other groups promulgated model language. Then they saw what happened, they liked some stuff, didn't like others. Now they're revisiting those statutes to bring them up to speed with the current delivery of telemedicine in the industry. Again, you also have that appropriately provided in the second bullet point, but then the other ones are pretty much identical. Maryland, though, to its credit, they say at the bottom, instead of that other DC, they say you cannot distinguish between rural and urban locations. Okay, Virginia. Virginia is an excellent statute. Shall not include a service solely because it's provided through telemedicine. Perfect, right? There are bases to exclude a service, but as long as it's not related to telemedicine, that's not a grounds. Insurer shall not be required to reimburse for technical fees or costs. So look, most states don't reimburse that. You know, if you have that kind of fee sheet, you just built in overall operating expense. I mean, I don't even have a problem with that as a pro provider side. It's almost just a giveaway to a plan. You know, Delaware is like, nope, we got to get paid for that too. But that's great if they give that. You know, there can be opportunity for give and take, but they shall reimburse the provider. Again, it's the affirmative. You will have to do this. For diagnosis, consultation, or treatment, okay? It's disjunctive, not and treatment. You know, these things really matter. Words matter, okay? Especially when it comes to statutory construction and how it's interpreted. It's very well done. And then on the same basis. They don't say on the same rate and the same basis. So I know you, all of you with the Virginia delegate, so to speak, would have a better idea if you're getting paid the identical rate or not. But you do have some language in there that upon which you can rely. And then again, the determinations must be made in the same way. You have patient shifting protection and must be equally imposed upon all terms. Minnesota, here's a recent one. It's another example of a good one. It's very simple. Health plan shall include coverage, blah, 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 and everything, okay? Shall not exclude coverage solely because it's provided via telemedicine. It shall pay the provider on the same basis and at the same rate. This is somewhat problematic to some people from a philosophical. Well, if it's the same rate and you're getting paid on a fee-for-service encounter and you want to have telemedicine as a capitated or hybrid payment, does that statute prevent you from doing so? In my opinion, I don't really think so. I think this sets the minimum. And if the two parties want to agree in contract to have something different from that, I think that's acceptable. Again, this is designed to be a patient's rights issue and to ensure that they will have coverage and payment parity. You know, if you didn't have that, good luck trying to, you know, talk about whether you're going to get like paid capitated or not. You know, you'll have to be much more proactive. Mississippi, you want to talk simple, all right? You know, keep it simple. Everybody in the state's got to provide coverage to the same extent that the services would be covered if they were provided through in-person consult. Doesn't get any simpler than that. Yeah, you can charge deductible, so it's the same. Here's a bad one. So we went, you know, Clint Eastwood, these are a bunch of good ones and from y'all's, and again, I'm sorry I left off Kentucky, but Arizona here, covered were it provided through in-person consult, okay, good, between the subscriber and the provider, and provided to a subscriber receiving the service in a rural region of the state. Wah, wah, right? Okay, so that's not very useful, okay? Then again, it also says, in fact, we can limit it to members of the corporation's provider network as well. And this is the ugly, okay, Michigan. Contracts shall not require face-to-face. Okay, first of all, if anybody still thinks face-to-face is the same thing as in-person, you know, it's not. In-person, we're in the same room. Face-to-face can be achieved via, you know, real-time video interaction or whatnot, okay? So the words really in the trend of how these are developed, in-person means physically in the same room. But shall not require face-to-face contact between the professional and patient for services appropriately provided. There's that wonderful appropriately provided language. Through telemedicine, and then you say, as determined by the insurer, the HMO. So really, this lets them do whatever they want, and as a result, like, there's hardly any coverage in Michigan whatsoever. Okay, what can we do about it? The Telehealth Association of Florida, they had a work group in telehealth for with the state for a number of years and really helped with education and advocacy, but they weren't getting much traction on a bill. And so they created the Telehealth Association of Florida, got a broad representation. Actually, you know, I have to give credit where it's due. Like Karen, she and I were on a panel last summer. She talked about the Virginia experience and how she enlisted not just the provider community, but really pulled in broadband providers, telecom kind of companies, in a multi-representative effort, and how much more powerful that was. And I was like, that's a good idea. I'm going to steal that idea. Okay? And so there, you know, it wasn't just Florida-based hospitals and healthcare providers. Certainly we had that. MD Live, they're based in Florida, right? Their headquarters is, there's no reason why they shouldn't be on it. Miami Children's Hospital, they have some really interesting telemedicine programs. They're on it. Orlando Health, one of the few ACOs in the country to receive incentive payments because their markers were so high, and they have a robust telemedicine and population health program. But we also had Cisco. Right? They were on the executive board. Walmart was on the executive board. Envision and Evolution Health was on the executive board. And so you had a bunch of members who really kind of knew their own lobbyists and their own like kind of pathways, and they collaborated in their efforts. We created 3 different versions of proposed legislation. One, we were like, let's think as outside the box as possible, right? And so we had one where it was like, yes, coverage was mandated, but it would give the health plans like a tax benefit for like a 2-year period, right? And then we said, well, maybe an opt-in type of a thing. And there are all different ways to think about this. And then we also folded in, if anyone read the DocFix bill that was enacted last year on the federal level, there were provisions in there requiring, I forgot which government agency, but to generate 2 reports on telehealth and the Medicare program, right? And they're due March of 2017, I believe. And they're designed to provide Congress with some external objective analysis of the budgetary impact of eliminating all of these conditions for coverage in telehealth services. I said, that's a great idea. Let me steal that idea too, right? So we put that in the bill, right? And so now the bill had a section creating a telehealth council within the Agency for Healthcare Administration in Florida and Department of Health, and then the Office of Insurance Regulation. And what they'll do is it'll be a 15-member committee, council, and they're going to survey all healthcare professionals, institutions, and health plans to say, what extent are you actually providing coverage? What claims are being covered and how much are you getting paid? And if you don't report this, we're going to fine you, okay? I presume a lot of the plans may not report unless they're actually providing the coverage, but I'm sure a lot of providers will. They'll generate a report, give it to the governor and the legislature, and they'll use it as objective evidence to understand the real market forces in the state of Florida, and then they can consider a telehealth coverage bill without just resorting to, it's a mandate, it's not a mandate, I'm a Republican, you're a Democrat, you know, whatever. And so really, that's what got, everything else got cut out, but everybody else could agree on that, and I think that will be the pathway for Florida to get a telehealth coverage bill. We already talked about revising the existing statutes. So here's some language to consider. All health insurance plans in this state must provide coverage for healthcare services provided via telehealth to the same extent the services would be covered if they were provided through an in-person consult or encounter. It's really simple, it's really clear, and it's a single sentence, okay? The second one, if you want that payment parity, there's a sentence for payment parity as well. Payment rates provided via telehealth must be equivalent or identical to payment rates for comparable healthcare services provided through in-person consults. And then a plan may not distinguish between patients in rural or urban locations in providing coverage. The plan may not limit coverage of telehealth services to those providers who are members of the insurance plan's provider network. Now that's pretty ballsy because only I think 1 or 2 states have something like that. And I can't recall off the top of my head, but they do. So you can be an out-of-network provider, right, and drop claims and get paid for telehealth claims under that law. And you know, if you're curious, you can always email me. And then finally, some patient cost-shifting protections. Oh. All right, so this, Telehealth Ride the Wave, on the right, Patrick Swayze, star of the best film of 1991, Point Break. And on the left, my 5-year-old son Bennett doing his best Patrick Swayze impression. And he gets dressed up in costumes in all my different slides. So here's my contact info. 2 points. That Healthcare Law Today is the blog. There's probably like 50 or 60 telemedicine articles. And @Lacktman is my Twitter feed, and so I was tweeting with the Matric hashtag throughout the conference as well. Not a ton of activity on it, but on that hashtag. But if you go to it, you'll see links to articles on law and rules for telehealth in like Virginia, West Virginia, DC's proposed rules, Delaware, and it's a full breakdown, and it gives you hyperlinks to the statutes and guidance, so you can do it all yourself. And I would like to thank everybody for having me here. It was a real pleasure. I think we're ending just almost on time, and if there's any questions, I'm happy to entertain them. United Healthcare is a virtual network tree of DTC providers. Yeah, a number of health plans do have their own in-house network because they realize the benefit. Like Anthem, for example, they have LiveWell. It's an app powered by American Well, developed the app, and the providers are Anthem-affiliated doctors. And so the health plan is able to realize both the cost savings for its enrollees of avoiding acute inpatient stays or urgent care centers, but they're also able to realize the direct line revenue of having their own affiliated medical group. So if they see the value, I'm sure a lot of health plans would see the value. I have United Healthcare through my employer as a benefit. They do have some telehealth coverage in some states. I don't have it in my state, and I don't have it with my employer. So again, it's you don't want to just draw. I'm not trying to paint plans in a bad brush, but you don't want to draw an overbroad brush to say United covers in telehealth, because it's absolutely not correct. Oregon argues that telehealth should be reimbursed at lower rates because it doesn't cost as much to deliver. How would you address the need to get paid at the same rate as face-to-face? Okay, so I don't think that it is fair or it makes any sense to say that you should get paid on a claim-by-claim basis less simply because you provided it via telehealth, okay? There are a number of efficiencies and throughputs and drivers that can make your whole operation run better and give you greater capacity to see more patients, thereby making more money. But that doesn't mean that someone who went to UVA med school, right, and trained up, that the value of their expertise and professional time in a consult that was delivered via telemedicine is worth less than if it was delivered in person, right? It doesn't mean that the investment of technology and equipment and hardware and training to deliver services via telemedicine is actually less than just maintaining a brick and mortar clinic. I would argue that it is more expensive than it is an investment. So the notion of paying the same rate doesn't generate any cost savings. I think it's true that paying the same rate doesn't generate any immediate short-term cost savings to the party responsible for the payment. But the party responsible for the payment has contractually agreed with one of its enrollees that it will pay for the healthcare services that individual needs. In exchange, that individual is paying them a premium every single month for that kind of access. Moreover, it ignores the fact that telehealth and increased access to these type of preventative care or specialist services can reduce the long-term healthcare costs. And who are those borne by? Not necessarily the provider delivering that urgent care access. It's going to be the health plan who then pays for an acute inpatient stay, or the individual who has unmanaged diabetes and all of a sudden has renal failure. Okay, then they have to go to a dialysis center. Health plan is paying for that, the individual is suffering. So I think that if the argument that Oregon generally would toss up, it kind of misses the point on the availability of the long-term cost savings. Again, and if people don't use telehealth, right? If you say, sure, I'll cover telehealth, but I'm going to pay you 20%, no providers will want to use it, right? And if nobody uses it, no patients will realize the benefit, and then they'll say, well, there's no studies showing that there's actually any long-term care improvement, even though we have these laws. Well, if no one's using it, you're not going to see anything. And the same principle applies in a lot of your contracts, which I personally disfavor in encounter-based only arrangements because they don't have both parties with some skin in the game. Thanks from Delaware. Okay. Any entity that might have some advocacy tools agencies could access and make them available to consumers to change Medicare. Yeah, I think some of the telehealth resource centers do an excellent job with that. I think that the American Telemedicine Association does an excellent job with that. I think that, I talk about it on some of my blog articles. Another really great source is Politico's eHealth morning report. David Pittman is the main editor. He is like phenomenal when it comes to breaking news and reporting and really solid understanding of these issues. So those would be the ones that I take. Also, that app development tool is totally rad. You know, I think OCR and some of the FTC, FCC, app developers are just like a grumpy bunch, okay? And like, no matter what these agencies do, people are gonna be kind of like, oh, it's not enough, I still don't understand. I get it, because you're a programmer, and then you're saying you don't understand this complex set of regulatory rules from multiple agencies. But they put out, I think OCR put out this really great 4-pager with scenarios, hypotheticals. I really have not seen that kind of effort and thought put by other agencies saying, let's apply this to real-world case studies and explain it to you, right? And then the app development questionnaire has really a high UX, user experience, compared to any other government website that I've navigated. And so I really would give them a lot of credit to try to make this access available. You don't need to go through lawyers to try to understand these decision tree points. Last one, with the advent of new network adequacy laws getting put in place, what are the key policy points to engage right in telehealth coverage and new quantitative standards provider to population? Okay, there's a lot of words here, but the Robert Wood Johnson report that I mentioned that's also tweeted with that Matric hashtag you can take a look at, they talk about this. So health plans, although they are subject to provider network adequacy rules, most states don't actually make any quantitative measures. They don't say, hey, you need to have a hospital within 30 miles of all of your enrollees, or 30 minutes to be seen. It's just like, okay, plan, you're attesting that your network adequacy is good, people are happy, no one's dying, okay, great, thank you, please sign here. That's really what it's been, okay? Now, what plans started to do a few years ago is really take narrow networking to heart and cut out a bunch of people. Because a lot of these contracts, even if you're in network, it says the health plan can terminate without cause and without reason your participation, and you're kind of disenfranchised. And they've done that by narrowing the networks. Typically in specialists, we see a lot of that in oncology, radiology, and they'll say, all right, you doctors have survived. We're going to pay you a little bit less, but you're going to get so much more patient volume because there's no other doctors in network. All these patients will go to you. I mean, and if it wasn't in the health plan context, you'd say, oh, that's kind of like a kickback, kind of a patient steering arrangement, right? Anyhow, that's what happened. Now these networks got so narrow that states are concerned. And so they've started to promulgate explicit quantitative standards that have to be met. The Robert Wood Johnson report talks about all that. Colorado is the only state that has promulgated explicit guidance saying you may use telemedicine to satisfy your network adequacy requirements health plan, and they set out rules on how to do it. And that's really great, because then you can be a health plan and have a network of, let's say, oncologists to reach out to patients all throughout the state, even in rural areas or whatnot, if they're via telemedicine, without having to necessarily have each one of them in brick and mortar locations geomapping where all of your different enrollees are. That's a pretty powerful access tool. Now, some specialties aren't conducive to it. They just necessitate in-person care, and that is what it is. But that's kind of that's kind of where it's at on that question. I think that's it, right? Okay.
Thank you very much.
Thank you.